Professor, can you come to the chair, please? We have now neuromuscular cases, I think. Now we have our colleagues, I'm very happy, from other universities. We have Mansoura University, Tanta University, Zagazig University. I'm very happy for your presence with us. And I think it's an opportunity also that Professor Bjarne Oud will see your patients and discuss your patients. And we are on time, don't worry. We keep 1 hour at the end before coffee break for discussion. We have to start late because you came late. We started 9:30, but we have 1 hour extra. Don't worry, you will have your time to present and discuss your cases. So we will start. The first case will be efficacy and safety of rituximab for new onset generalized myasthenia gravis. This is presented by Dr. Dina Ghazawi, Dina Ghazawi, Mansoura University. تفضل يا دينا.
Good morning, everyone. Good morning, our professor. Thank you, Dr. Nagia, for this opportunity. I'd like to present 2 cases from our Mansoura University Hospital. Both cases have received rituximab. So let's start by the first one. This is Mr. M.A., right-handed male patient, 80 years old. He is director and married with 2 offsprings and ex-smoker. Admitted to our Mansoura University Hospital complaining of fatigability, swallowing problem of subacute onset and fluctuating course 8 months ago. There was no relevant family history nor past history. The condition started 8 months ago by transient weakness and easy fatigability that was worse at the end of the day, and the condition was associated with bulbar symptoms, proximal limb weakness, and truncal muscle. Till the degree that affect the daily living activity of the patient. The condition also deteriorated within few months from the diagnosis and was associated with neck sagging and more disabling symptoms. But till the time of the admission, the patient didn't report any ocular nor respiratory symptoms. Then the patient was admitted to our university hospital and confirmed to have diagnosis of late onset generalized myasthenia gravis based on bedside test, electrophysiological study, and serological test. And also the patient underwent CT shots that revealed normal thymus. The acetylcholine receptor antibody was positive with high titer. Also, we have done band-CT with contrast that reveal no abnormality. By examination, the patient generally was normal. And as regards the neurological examination, the patient had only diminished gag reflex and motor weakness that affect proximal muscles and truncal muscles. The patient, according to Myasthenia Gravis Foundation American scale, achieved 3B score, seropositive, and the most prominent symptoms was bulbar symptoms of moderate disability. Also, about the quantitative Myasthenia Gravis scale was 19, and the ADL score was 15. We tried to reach step by step in the treatment algorithm. We tried to achieve one of the best treatment score here. We have 3 scores. We have minimal manifestation and complete stable remission and pharmacological remission. The minimal manifestation score defined as the patient have no symptoms or functional limitation, but by examination I can see some weakness of some muscles. And according to the patient received treatment or not, I can subdivide it into 4 grades. About the complete stable remission, this patient have no symptoms, no functional disability, and by examination I couldn't see any muscle weakness except some residual weakness of eye closure. And at need that, the patient had no therapy for minimum period for 1 year. About pharmacological remission is the same, the complete stable remission, but here the patient can receive some therapy apart from symptomatic treatment. So by following the treatment algorithm, the first one, the patient starting symptomatic treatment, but there is no good symptom control with symptomatic treatment. Patient didn't have thymoma, acetylcholine receptor antibody was positive, and the age was more than 65, so thymectomy not recommended. So we have started prednisolone and high-dose regimen. The patient started to improve with marvelous response on the steroid therapy, but unfortunately the patient has high random. Checked the hemoglobin A1C, and the patient recently discovered diabetes. So we tried to withdraw the steroid and starting steroid-sparing therapy. But unfortunately, the patient had a crisis and neck sagging at this time. So we admit the patient in our hospital and started plasma exchange as rescue therapy and the first dose of rituximab. Here the patient achieved the minimal manifestation score with marvelous response to the treatment, and the quantitative myasthenia scale was 4 and the ADL score was 0. We have also another patient. The patient nearly have the same clinical data, but totally different clinical scenario. This patient was female patient named Mrs. H.A., aged 69 years old. She was housewife, married with 4 offsprings, with no special habit of medical importance. And the patient admitted with recurrent symptoms of a swallowing problem, double vision, subacute onset, fluctuating course 4 years ago. No relevant family history, and the post history, the patient was hypothyroidism on medical treatment, and the patient was controlled. The condition started 4 years ago by ocular symptoms, double vision with bilateral asymmetrical ptosis and easy fatigability. And the patient diagnosed here to have ocular myasthenia gravis with very controlled symptoms and symptomatic treatment for 1 year. The patient underwent CT chest that revealed normal thymus, and the patient also have acetylcholine receptor antibody with high titer. Then at the second year, the patient progressed to have complete ptosis, persistent all the day. So Sulopenem was prescribed and the symptoms controlled for another 1 year. But in the third year, the patient sadly have 3 crises and admitted to our hospital in this year. The first time, the patient had pulpar symptoms with nasal regurgitation, admitted to ICU and underwent Plex for 5 years and discharged on aid immune modulating therapy Imuron with increased dose of Sulopenem. But 2 months later, the patient after discharge had another crisis with severe pulpar symptoms, complete ptosis, and admitted again to have plasma exchange, but she was still on the Imuron as its action hasn't been reached at the same time. It's only 2 months. And at the end of the third year, we had another crisis, pulpar and respiratory muscle, axial weakness, and the patient was on Imuron at this time, so underwent the third time in plasma exchange at the same year for 8 sessions, followed by IVIG, and discharged on moderate improvement, but with shifting to Celsip. And she regained some EDL. 9 months later, the condition worsened with respiratory failure, mechanical ventilation, and rescue plasma exchange, so was extubated and discharged on the first dose of rituximab. But unfortunately, the patient didn't respond well to rituximab even after the second dose. And the patient now, she is well shared, and about the respiratory and pulpar ocular muscle, she had moderate improvement. By definition, the patient already achieved the refractory definition of the myasthenia gravis. According to the Myasthenia Gravis Foundation American scale, it was 4P at the start, and quantitative myasthenia gravis scale 22, and the ADL was 17. We also tried to follow up the steps for algorithm approach, starting symptomatic treatment. Patient respond well initially at the first year. Patient didn't have thymoma, and acetylcholine receptors positive will age more than 65, so it was recommended to do thymectomy. We started prednisolone in high dose regimen, initial control with steroid regimen, then relapse. At the third year, we added immune suppression treatment as azathioprine and then Celsip, but the patient couldn't achieve a minimal manifestation score with recurrent rescue treatment and ICU admission and worsen. So lastly, we had a rituximab 2 cycle, but unfortunately, the patient also didn't achieve the minimal manifestation score. We saw the same patient. 2 patients have the same clinical data, both of them late onset generalized myasthenia gravis, and at the end they have reached the rituximab. But the difference between them, one had started it as the first year of the diagnosis, and the second achieves it at the 4th year of the diagnosis. So what is the trick here? We also know that the pathogenesis underlying the myasthenia gravis starting from the thymus, but also it affects the B cell. We have different types from the B cell. We have short-lived plasma cell and long-lived plasma cell. We have memory B cell also. The rituximab actually acts on CD20, and CD20 is present only, or not only, mostly as the short-lived plasma cell and the memory cell. So if we started the rituximab early to attack the CD20, which is present on the short-lived plasma cell and memory cell, it will act very effectively. But if we left them lastly in the treatment approach, it will build up in the disease course, and we will have plenty of long-lived plasma cell. So each action theoretically wouldn't be the best that I want. We have some evidence based on some clinical trials. This is one from Journal of Neuromuscular Disorder, which under the title of efficacy of rituximab in refractory generalized anti-acetylcholine receptor myasthenia gravis, and the disease course here ranging from 3 years up to 32 years. And the primary outcome here was to reach the minimal manifestation score at the 12 months, but unfortunately only one had achieved the minimal manifestation score. Also, we have another one published in 2021 about phase trial of rituximab in acetylcholine receptor antibody positive generalized myasthenia gravis, which called the Beat Myasthenia Gravis study. Also, the primary outcome here was steroid sparing effect. And secondary outcome was safety and achieving the good quantitative myasthenia gravis score. It was two-arm, double-blind, placebo-controlled study, one receiving rituximab and the other receiving placebo, but the primary outcome achieved in 60% of the rituximab versus 56% in the placebo group. So it appeared to be not efficacious. But here in 2020, there is one article about comparison between rituximab in two groups, new onset generalized myasthenia versus refractory myasthenia gravis. We have two arms. They have divided them into 24 new onset generalized myasthenia gravis receiving rituximab and 34 refractory one receiving rituximab versus 26 new onset receiving conventional immune therapy. And they found that marvelous response within short time. About 80% from the population achieved, from the patient with generalized myasthenia gravis achieved about 80% achieved the minimal manifestation score within 20 months. And in the second graph here, we see that the patient with new onsets, they have the upper hand of improvement rather than the patient with refractory generalized myasthenia gravis. Also, this was about remission in patient with new onset generalized myasthenia gravis receiving rituximab versus conventional immune suppression. It also was about in favor of rituximab. And also, in addition to that, fewer rescue therapy episodes during the first 24 months was required in the rituximab group. And also, the rate of discontinuation due to adverse effect was lower in the rituximab group in comparison to the other immune suppression treatment. Even when they tried low-dose rituximab treatment for new onset generalized myasthenia gravis, they found that the patient achieved the minimal manifestation score and they were controlled for about 50 months period, and they was good in withdrawal and discontinuation of the steroid treatment. And this last one in 2022 about the efficacy and safety of rituximab for new onset generalized myasthenia gravis versus placebo. It was randomized double-blinded placebo-controlled study between 33 men and 14 women from 7 tertiary hospitals in Sweden, and they divided them in two arms, one with 25 patients receiving rituximab and 22 receiving placebo treatment. And the primary outcome was achieving minimal manifestation at 16 weeks and achieving quantitative myasthenia gravis score less than 4, and withdrawal of erythropoietin to be less than 10 milligram daily. And they found that about 70% of rituximab achieved the minimal manifestation score. And also, at the end of the study, they were successful in withdrawal steroid therapy in the rituximab group and achieving the best clinical assessment scores in the rituximab group. Also, they found that the adverse events, as regard the fatal severe adverse event, there were one only in the rituximab group, and the life-threatening condition, 2 in the placebo group. So in conclusion here, we have the rituximab, which theoretically acts about short cell lived plasma cell. So we conclude that there is relatively greater benefit of rituximab earlier in the disease course and should be considered earlier in the treatment algorithm for non-mask generalized myasthenia gravis. And rituximab appeared to be more favorable in new onset generalized myasthenia gravis, and even single infusion of rituximab increased the probability to attain minimal manifestation score and improved the outcome with good tolerability. So if we want to add rituximab for patients with generalized myasthenia gravis, I recommend that to raise it up in the algorithm before the disease course build up to chronic one to get better efficacy. Thank you.
Thank you, Gina, for raising up this subject. It's very important.
Thank you.
And we know that intractable or refractory myasthenia gravis in Egypt is a problem because we don't have drugs. We don't have the drugs for refractory myasthenia gravis. We recently started in the last 3 or 4 years to introduce rituximab in myasthenia gravis.
Yeah.
And also you will have the new molecule ravulizumab in the conference in Unit.Day. So please attend the symposium because we will discuss this. We have some questions, Dr. Isam. Can you help with that?
زي ما حضرتك بتقولي يا دكتوره ناجيه، هو المعروف ريتوكسماب في الريفراكتوري مايسينيا، بس يعني الدكتوره قالته دلوقتي لا، ان احنا يعني يعتبر بقى ان هو فيرست لاين تريتمنت.
Yes, because most of these autoimmune disorders, as we will raise in the symposium, at first when it is still early, there is no destruction or permanent affection of the post synaptic membrane, and there is no affection of these short-lived plasma cells. So this will be the debate, to use these drugs early or wait until it is refractory. In Egypt, we have a problem in the refractory one. And now we have a problem that we have to use these drugs, especially the new expensive drugs. We have to use it early to save our patients and prevent them for being refractory.
بس still مفيش جايد لاينز، يعني كلها لسه بيبرز وستاديز، لسه مفيش جايد لاينز ان انا برضه استخدم ريتوكسماب ايرلي في الايرلي onset myasthenia.
This is her hypothesis. She raised this debate for hypothesis that why we don't use early. When patients used early, it is giving good results. When we wait, even if you have a patient with refractory myasthenia, you find first or second year responsive to rituximab. Then the patient became non-responsive to rituximab. Okay. This is why also I observed after. What's your experience, Professor?
No, I think I do not have much to add to this. It is very clear that many centers now move from using rituximab in refractory cases to use it earlier.
Okay.
I have
Dr. Heba?
thank you so much for this presentation. I want to ask about your experience, either you or Dr. Nagy or Dr. Ott, your experience with rituximab in myasthenia gravis. So my protocol in CIDP is that I give the patient 1 gram and then repeat it after 2 weeks and then every 6 months. And I request first of all CD20, and I retreat if CD20 count by flow cytometry is more than 1%. So is it the same protocol we use in myasthenia gravis?
Yes.
We don't do CG20. You do?
No.
No. Do we have in Egypt flow?
No,
We do.
No.
We do.
We have in Egypt?
I requested the CD20 from one of my patient with CIDP, and she did it.
Okay, very good. How much it costs?
I didn't ask her because I didn't know that this is a problem.
Yes, but if it is present in Egypt, we have to put it in the guidelines, and we have to establish our guidelines according to the drugs available in Egypt.
And for how long do you keep the
Yes.
patient on rituximab?
Dalia Gina.
There is some papers talk about low dose rituximab, only about 100 milligram for 1 week, 3 weeks consequently. Okay, and we can
Would you please repeat it again? 100
100
milligrams?
milligram for 1 week 3 times. Okay, and then we ask for CD19 and we will show the result. If more than 1%, we can add another 100 milligram after 6 months, once only. Okay, and they found that this is very effective in patients with new onset generalized myasthenia gravis. Also في some patient some centers يعني approve ان هم يدوا 1 gram then after 6 months they can do the another course of 1 gram, and also the but not in Egypt. Okay, outside Egypt they can do CD19, and according to the amount, if more than 1% they can take another course after 6 months.
CD19, not
19.
CD20.
19.
Okay.
Not
Is
CD20.
there a reason?
Oh, okay. On
No,
all
I
papers-
mean, why don't we request CD20 instead of
okay,
CD19?
but on all papers they ask for CD19 and CD20 they as an NMO الانتيبودي او monoclonal antibody زي act on B cells, they have CD19 and CD20. Okay, but in all papers they searched for CD19, not CD20.
I see. And for how long do you keep your patient on rituximab?
Two cycles, and if the CD19 more than 1%, they can do another 1 cycle.
So
Okay.
total maximum,
Maximum
3
three-
cycles.
Maximum 3 cycles, but in literature they write 2 years, for 2 years only.
4 cycles, you mean?
Oh,
Yeah, thank you.
But
Thank
there is another protocol like the CIGP and MS protocol. They give either half gram, then after 2 weeks another half
okay,
gram, then
1 gram
every 6 months.
Oh.
Or they give it according to surface area and the square meter, so they put. Actually, I use the rituximab with this protocol. I give the 500 or 1 gram according to the body weight, and then after 2 weeks I give another dose, then every 6 months. What I observed is after 2 or 3 cycles, when the patient is responsive, then I have to prolong the period every 8 months, then every 12 months. Then after 2 years, some patients are in a remission and don't need any more for rituximab. But this is another regimen, and we must read about this.
We in Mansour University Hospital use the same protocol of yours, but I see some papers now talking about low dose rituximab in patients with new onset generalized, not refractory generalized myasthenia gravis, from the start to build up to prevent the building up of the disease. Okay.
I have a question, last question, please. Do you think it's wise to use rituximab if we compare ourselves to the, worldwide, they have other options that are strong enough? If we don't have other options, and there's expected that some patients in 2 or 3 years will be resistant and they won't be, having any benefits from the rituximab, but you can shift to a weaker drug then. So do you think for us in Egypt, with our possibilities and limited possibilities in the medications, do you think it's wise to use it from the start in a generalized patient?
From our experience in Mansour University Hospital, all patients with refractory myasthenia gravis receiving rituximab not improving. Okay, in all my residency time, I didn't meet a patient who improved on rituximab, and the patient was refractory myasthenia gravis. Now we approaching the patient with generalized onset myasthenia gravis, and from the start, if I think I don't say I should start rituximab from the start, but if I need for rituximab, I must build it up in the algorithm, raise it up in the algorithm, not wait after the disease has progressed in the chronic form. Okay.
So I think I was talking with Dr. Ahmed Nasruddin from Asyut University, and I asked him to put the guidelines, and we have to do a committee to start to put the guidelines for myasthenia gravis in Egypt with the availability of the drugs and the cost effectiveness, because the new drugs, the complement mediated, will be very expensive. But if you compare with this patient with several admission in hospital and plasmapheresis and ICU. So, and the chronicity. So we must revise all of this. Thank you, Dina, so much for raising this subject. And I think we will shift to the second speaker. It's also Mansoura about myasthenia gravis. Myasthenia gravis in patients with positive LRP4 antibodies. This is Dr. Iman Isa, Mansoura University.
Welcome, our professors and colleagues, and I'm very proud to be with you all here today. It's my first time to present here in Ain Shams University. Thanks to Professor Nagia for sure. I'll try to be very brief, but this is an important topic, okay? It's about myasthenia gravis in patients with positive LRP4 antibodies. Okay, I'll start with an interesting case presentation. He's a 19-year-old male patient who was referred to the Department of Neurology, Mansoura University Hospitals, as he had reported double vision. He's a right-handed student, single, with no special habits of medical importance. He had no family history of similar condition, nor consanguinity with irrelevant past medical history. The condition started approximately 2 years before his first visit to our hospitals. He began to complain of double vision when looking to his right. The symptom lasted for a month and then spontaneously disappeared. However, 2 months later, his double vision reappeared again. So he sought medical advice. On an examination during that visit, limited ocular movement ptosis was not confirmed with certainty. So he just was advised to take some supplements and just follow up. Then 1 year after his first evaluation, he noticed mild dropping of his left eyelid with limitation of movement of left eye towards right side. That was not associated with diurnal variation or fatigability or affected with rest, exercise, or any temperature changes. So he sought medical advice again. They thought about myasthenia, but due to there was no fatigability or diurnal variation, they decided to do MRI brain that was normal, and the fatigue test was negative. And then he was diagnosed as left oculomotor nerve palsy without etiological diagnosis. He received then on-home treatment, betamethasone 2 milligram ampoule once for 2 days only, prednisone 20 milligram tab once daily for 2 weeks, cereprolizin 5 milliampoule every 3 days, Tri-P 1 milliampoule every 3 days for 2 weeks. Then he improved totally without any residuals, and he didn't take any other medication after that. Then he presented 6 months later with nearly complete dropping of his left eyelid with obvious external squint and limitation of movement of left eye towards his right side. Therefore, he was admitted to our hospital for further investigation. At that time, by history taking, there was diplopia, appeared only on elevation of the lid. It was horizontal, increased on looking to the right side. The symptoms were not associated with fatigability, diurnal variation, or changed with exercise or temperature. Also, it was not associated with any other cranial nerve affection, pulpar, or any generalized muscle weakness. So he was pure ocular. By examination, the patient appeared well with no specific features, with average build, average vital signs, and normal general examination. He had left eyelid ptosis that was not corrected with the eye SPAC test or the nystagmus test. The left medial rectus muscle was only affected in limitation of the movement with normal pupil examination. He had normal speech, normal counting test, normal facial pulpar examination. He had normal muscle state, muscle power examination, and he was power grade 5 all over. With investigation, we did the laboratory routine tests, including the CBC chemistry panel and the thyroid function, and they were normal. Then we did the myasthenia gravis antibodies Serum anti-acetylcholine receptor and anti-MuSK antibodies were not detected. However, we find positive LRP4 antibodies. The repetitive nervous stimulation tests for this patient were performed in the bilateral abductor digiti minimi muscles and the left trapezius, left orbicularis oculi muscles at the slow and the fast rates, 3 and 30 Hertz. The results showed no decremental or incremental responses for the compound muscle action potentials. However, the single fiber EMG was non-diagnostic due to poor cooperation of the patient. The cranial MRI revealed no abnormal interstices or aneurysms. Also, the CT chest showed normal thymus gland. So we diagnosed this patient as a positive LRP4 myasthenic patient according to the Myasthenia Gravis Foundation of America clinical classification. He was only ocular, class 1. And in the Myasthenia Gravis composite scale, he had a 7 score. And on the Myasthenia Gravis activity of daily life profile, he has 6 score with normal strength and extensive manual muscle testing. Then he was discharged on oral steroid. We gave him prednisone 30 milligram every other day and pyridostigmine 3 tab daily that offered some benefits to his symptoms, but it was not completely resolved. His symptoms worsened shortly after the diagnosis. It was not severe symptoms, but it interfered with his studying as he was a student. And it was very agonizing to him, and that led to readmission. That time we tried giving him IVIG that showed significant improvement in his symptoms with 4 score in the Myasthenia Gravis composite scale, and it was only 2 in the Myasthenia Gravis activity of daily life profile. The pyridostigmine was tapered off totally, and the prednisone dose was decreased by 50%. Evaluation at 3 months later demonstrated stable course with significant improvement. So, simply, we all know that myasthenia gravis is an autoimmune disorder of the neuromuscular junction in which the patient have selective muscle weakness, which is fluctuating or variation, whether diurnal or seasonal and so on. It's relatively uncommon. The prevalence is about 150 up to 300 per million population with 10 per million incidents per year. However, the pathogenesis of myasthenia is very complex. We all know that mostly it's antibody or it's autoimmune against the neuromuscular junction structural or functional components, which are thought to be the main mechanism is the antibodies against the acetylcholine receptor and smaller proportion against the MuSK or LRP4 instead. LRP4, it's lipoprotein receptor related protein 4, which is a family of the lipoprotein receptors. We all know the lipoprotein receptors is usually affecting neurological diseases like LRP1 in the stroke, LRP2 found sometimes in ALS, and also LRP4 found sometimes in ALS, not only in myasthenia gravis. It serves as a receptor for the agrin in the neuromuscular junction. The agrin is, has a pathway with the MuSK. It's called LRP4 agrin MuSK rapsin pathway, which all acts as clustering, triggering for the MuSK. Okay? For the MuSK and the acetylcholine antibodies. Because of its role, antibodies against the LRP4 have been identified as the third pathogenic autoantigen in myasthenia. The identification of antibodies is a key step in the workup of myasthenia, as it not only confirms the diagnosis, it can dictate the appropriate treatment too. So we did a case control study in our neurology department, Mansoura University Hospital. We took 50 patients with myasthenia gravis. All of them underwent neurological history taking, general neurological examination, myasthenia gravis composite scaling, repetitive nerve stimulation, CT chest, anti-LRP4 antibody testing, and only 4 patients were positive. None of the control group showed positivity. We should know that LRP4, about 2 to 10%, may be found in normal population. Brief conclusion about the results. As regard the anti-LRP4 positive patient mean age, it was 21 plus or minus 3. It's younger than the negative anti-LRP4 patients, and that showed a statistical significant difference. Most of the positive anti-LRP4 patients were female, 75%. We have 4 patients, 3 of them were female, and only 1 was a male. The median duration of the disease of positive anti-LRP4 is lower than that of the negative. It ranged from 1 to 3. However, we know the positive acetylcholine antibodies can range from 1 up to 30 years and so on. None of the positive anti-LRP4 patients reported history of crisis, ICU admission, mechanical ventilation. However, that didn't show a statistical significant difference. As regards the clinical presentation, all anti-LRP4 positive patients had ocular weakness, facial pulpa, and limb. Only 1 of them had neck and respiratory weakness. As regards the examination, none of the positive patients had distal muscle weakness. Only 3 of them had mild proximal muscle weakness, and we said 1 was pure ocular. And that showed a statistical significant difference from the negative ones. Comparing the myasthenia gravis composite scale mean between the positive and the negative, it was also lower for the positive one. And regarding the Myasthenia Gravis Foundation of America, 1 of them was grade 1 ocular and 3 was grade 2P, which is mild generalized. However, that was of significant statistical difference. Okay. All positive anti-LRP4 patients had normal CT chest, and 3 of them had the positive repetitive nervous stimulation. There was no statistical difference in the usage of a steroid or any other immune suppressant among the positive or the negative ones. However, none of the patients, the positive ones, received Plex or IVIG or did thymectomy. All the positive anti-LRP4 patients were good responder with good prognosis. So simply to conclude, we found 8% of our myasthenic patients positive for LRP4, and this is a high percentage for the LRP. It's the only study done in Egypt for LRP4 positive patients. I think it's about 1 up to 10%. It's a wide range all over the world, but here it's 8%, so it's a high range. Okay, and it's 3 of them were women, so it's more in women, younger age, ocular and mild to moderate symptoms, normal thymus, positive repetitive nervous stimulation, got the response to the therapy and better prognosis. So it's very important to address all the autoantibodies in myasthenia gravis to educate their role in myasthenia, because they should be introduced as a protocol for the therapeutic strategy, and it should be tailored according each patient. Still till now, there is no guidelines for treating the LRP4 positive patients. It's all trials, only trials, and we did say that rituximab is good for the refractory myasthenia in the previous session, and it's also new trials advising rituximab in the very mild patient with LRP4. Okay. Also, we recommend developing the antigen-specific therapies and targeting only the autoantibodies involved. And thank you all. Thanks for neuromuscular team, Mansoura University, my team, and my team in Newcastle upon Tyne Hospitals, NHS. Thank you all. Thank you, Dr. Naga. I tried to be very fast. Sorry for this.
No. Thank you, Iman, so much for your excellent presentation.
Thank you
and
so
your
much.
excellent work.
This
is the first work done in Egypt for these LRP4 antibodies.
Yes.
And you did this through your thesis and
Yes.
project, or in a
was my
commercial
thesis.
lab?
No, it was my thesis.
It was in
My master
Newcastle
thesis.
or in Egypt?
In Egypt here.
So you did with immunology department,
Yes.
and you did it for the
All in Mansoura University.
in Mansour, yes.
All the
yes.
work is in
very
Mansoura
good,
University,
very
yes.
good, because we know that ocular myasthenia is different from other myasthenia.
Yes.
Different in presentation, different in neurophysiology, in antibodies, in response to therapy. It's different category. So Iman solved a good, a mild but an important portion of patients when you have only ocular myasthenia, and you know clinically it is ocular myasthenia, class 1 in the American Foundation classification. Then you did the antibodies, it's negative, and anti-mask and astartic negative. You did the neurophysiology, it is negative, and you start to give the therapy.
Empirically, first we started.
First, you start with pyridostigmine, no response because it doesn't cross the blood-brain barrier. So most of these patients don't respond to mistinone or to pyridostigmine. Usually they respond to high-dose steroids.
Yes.
They need high-dose steroids. This is a very important entity and subdivision of myasthenia, and still I think you will have more and more work about this ocular myasthenia. Questions to Iman. I want a lot of questions. Keep your
Thank you so much. Thanks for the great work, great job, and great presentation.
Thank you so much.
Did you look for seroconversion in your patients? Because for me, and it's not for me, but I think that the role of LRP4 in myasthenia gravis is debatable, and the reliability of these antibodies is questionable. Before testing LRP4, I would first go for repeating acetylcholine receptor antibodies and MuSK antibodies to see if there is seroconversion. So how did you look for seroconversion?
First, I just want to comment that it's not as reliable as you said, because recently, last year, it was confirmed that the pathognomonic antibody for myasthenia gravis is no more reliable one, okay? Then I want to comment. The first patient, the case presentation, we repeated twice, or I think he repeated it too much. He was young when he started. He was just 17 years old. And they tried to find acetylcholine, I think, twice or 3 times. Okay, but for my thesis, no. I haven't repeated anything, unfortunately.
Thank you, and great work. Thank you.
Thank you.
السؤال كلينيكالي العيان اللي حضرتك ذكرتيه ما كانش فيه فاتيجابيلتي ولا دايورنال فاريشن وريبيتيف نيرف ستيميوليشن. ده كومن في الهيرب 4 في الفور بيشنتس اللي حضرتك لقيتيهم في الستادي؟
No, he was the only one.
يعني المور كومن ان في فاتيجابيلتي وفي diurnal variation.
Diurnal variation and fatigability, they were present in the 4 cases, and they all or 3 of them had positive repetitive nerve stimulation also. But this patient, he was very challenging. He has no diurnal variation, no fatigability, negative repetitive nerve stimulation, negative antibody testing twice or 3 times. Yes.
Thank you.
Thank you.
Thank you so much for your case, your presentation.
Thank you so much.
Myasthenia is a very difficult topic in neurophysiology. I speak from neurophysiological aspect of view. Yes, normal. But I noticed that you said you perform the repetitive nerve stimulation, slow and rapid, which is 30 hertz, which is very painful to patients.
Yes.
How can you do this to patient? There is another way, replacement for this, not painful for the patient. Why you choose this method, and how can you perform it? How the patient can withstand this 30 hertz stimulation, and they cannot withstand single fiber MEG?
Okay, I comment for this. I haven't done the 30 hertz only for the case presentation, the patient who was challenging, not for the 50 patients in the thesis. Okay, it was not in my protocol to do the fast repetitive stimulation. Yes, it's very painful. I only did it for this patient because he was very challenging with no diurnal variation. So we have to do the whole protocol for the nerve conduction or the repetitive nerve stimulation. Why he can't cooperate the single fiber? And this, I can just say that unfortunately, in our department, Mansour University, we haven't the monopolar single fiber EMG at that time. Okay, so one of our colleagues just have it in her thesis. So I used a new needle. It was disposable, but I think it was very painful. I don't know why at that time, and I just tried it ocular only. So it was very, very painful to the patient, and he cannot at that time cooperate with me. Unfortunately, yeah.
But you did just once.
Yes.
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 Because
just once, and I couldn't repeat it.
It's difficult. So we can withstand this by sustained contraction to the muscles for.
But we can change from the neurophysiology for the hertz. We can change the volume of the impulse. to be less painful. You know that? When we do the 30 hertz, we can change, yes, okay, we can change it to be located, to be not, I don't know how to say it. You know?
قولها بالعربي. قولها بالعربي.
Yes.
No, I'm just speculating what you want to say. So, do you say that by changing the intensity, by going down in intensity,
Every
it's
impulse,
less painful?
Yes, every pulse
Even if it is
have
fast trip?
certain frequencies. Yes, not
Okay.
only the 30 hertz on the millivolt we can change. We can also change the frequency of each impulse. We did the 30 hertz, 30 impulse, but we can each impulse be of lesser frequency to be less painful. You know.
You're talking about the train of impulses or frequency? Frequency. Okay. So you did it at 30.
Yes, 30 hertz. But each impulse has a little millivolt.
You mean duration?
Yes, the intensity.
Intensity.
Yes.
I see what you're saying. Thank you.
The intensity of each impulse. The frequency is 30 hertz, okay? هو احنا بنعمل الانتنستي على 30. اوكي بنتشنج من 3 هرتز الفريكونسي سوري بنتشنج من 3 هرتز ل 30.
سوري الانتنستي مش على 30. الانتنستي انت بتعملي النيرف كوندكشن العادي لحد ما توصلي للماكسيمم ريسبونس وات ايفر يو انكريز انتنستي.
بالظبط.
اوكي and then add on 25%. This is super maximal estimation for myasthenia. Not for each patient. No, for each patient separately. Perform nerve conduction once you to the top. And 25%. So if you reduce the intensity, this test is not, I guess, not correct because you didn't get to the super maximal stimulation for myasthenia.
وانا مش اكسبرت قوي في الحته دي فعشان كده مش عارفه اقولها. Yes.
This is the first time for myself to see that anyone perform 30 hertz stimulation. This is the first time for me. Yes, first time for me.
اللي انا عايزه اقوله ان انا بعلي الانتنسيتي على حسب البيشنت above النورمال تمام بس في السيتنجز بتاعه الجهاز نفسه الانتنسيتي بتاعه each impulse دي اللي انا حاولت اقللها شويه.
Okay, thank you.
Thank you so much.
And welcome to the club. I hope every year you will be with us
Inshallah.
in
Thank you, Dr.
our school and conference. Thank you, Iman.
Thank you so
and
much.
We will continue the discussion on the coffee break. We have the next speaker, Dr. Ahmed Sami. Dr. Ahmed Sami is very interested in neuromuscular disorders, and he will continue Tanta University. Dr. Ahmed will talk about autonomic dysfunction and overlooked stroke risk in diabetic patients. A case presentation. تفضل يا أحمد.
Thank you, Dr. Nagia. You are my idol in the neuromuscular field. So, 54 years old housewife from Tontan complained of moderate right facial pain and numbness of acute onset that was almost constant throughout the day for nearly a week. She had a past history of diabetes mellitus for 7 years, and now she is on insulin therapy and metformin. Also, she is hypertensive on enalapril and had a history of dyslipidemia with no active treatment. Her recent lab findings were as follows: elevated HbA1c, total cholesterol, other routine lab non-significant results. She had an MRI brain that showed acute left thalamic infarction. Meanwhile, she complained to her stomatologist of dizziness, headache, feeling faint, especially on standing up quickly, and these complaints have been bothering to her for the last 6 months and become more evident in the last few weeks preceding the stroke incident. He just reassured her and advised her to watch out for her blood pressure, keep her hydrated all the time, and revise her endocrinologist for proper adjustment of her blood glucose levels. 5 months later, she came to us complaining of burning pain in both feet, particularly at night. Neurological evaluation. Here anthropometrics is weight, height, body mass index, and also elevated weight circumference, blood pressure. She was diagnosed at having metabolic syndrome, and actually all the criteria of the metabolic syndrome were met. Our somatosensory and motor evaluation, we have done the DN4 questionnaire, 4, Toronto Clinical Neuropathy Scale, 6, and categorized as mild neuropathy. Not very sensitive in the mild neuropathy, the Toronto Clinical Neuropathy Scale. The Utah Early Neuropathy Scale was 6. And the 11-point numeric pain scale was 5. Here, autonomic evaluation, the composite autonomic symptoms scale, the short form, the 31 question form, where total 41. Different cutoffs are out there in the previous research. Our elective physiological evaluation, the routine nerve conduction was normal. The cutaneous silent period, here is the routine nerve conduction. Cutaneous silent period were delayed onset latency. Here's the left median onset latency, 86.8. And the right sural nerve, 133. Actually, there is no studies for normative values in Egypt. I think our colleagues in Cairo University are preparing a study on the normative values and the cutaneous silent period. But previous studies showed that the onset latency of the median is supposed to be not more than 76. Also, for the sural, not more than 126. And this is the sympathetic skin response. The amplitude in the hands were decreased. Also in the both feet. The heart rate variability by RR interval analysis, we have done this using an sample EEG, sample EMG. We have just connect the electrodes on the median nerve, both median nerves, and measure the heart rate. And by several maneuvers, we actually measure the heart rate variability. You know that the heart rate is at the basal level is controlled by the vagal nerve. So by active standing, deep breathing, Valsalva maneuver, these maneuvers detects the change in the vagal tone. These are the blood pressure tests. Unlike the heart rate tests that are that represent the parasympathetic affection, the blood pressure test represents the sympathetic affection because at the basal level, the blood pressure is controlled by the sympathetic tone. We have done have measured the systolic blood pressure after active standing and the systolic blood pressure after sustained hand grip. These are the interpretation of the Eyring battery, and this is the classification. Our patient result, the 30-50 ratio on active standing was abnormal. Here's a control for just demonstration. The expiry to inspiratory ratio was also abnormal. And here's a control for for demonstration. The Valsalva ratio is abnormal. And here's a control for demonstration. Systolic blood pressure on active standing decreased more than 30 millimeter mercury, and this is abnormal. And also the systolic blood pressure didn't increase more than 16 millimeter mercury, and our result here is 15, and this is just borderline. So the Eyring classification, the patient has severe autonomic affection. We have done vagal nerve ultrasound. Actually, the controversy about its role in autonomic affection, some just see that a cutoff of 2.5 millimeter is the normal. The below this level is abnormal. Some studies just didn't find any significant difference between patient and controls regarding the cross-section area of the vagus nerve. Here are the online and offline measurement of the left vagal nerve and also the right vagal nerve. So the diagnosis: patient had ischemic stroke, lacunar infarction. Patient is diagnosed with the metabolic syndrome, and the patient has diabetic small fiber neuropathy, severe diabetic cardiovascular autonomic neuropathy. We will just take a look at the case as if metabolic syndrome that led to diabetic cardiovascular autonomic neuropathy. Recent study has suggesting that not only diabetes can lead to the diabetic cardiovascular autonomic neuropathy, but also metabolic syndrome per se, regardless diabetic profile, can lead to the diabetic cardiovascular autonomic neuropathy. And also metabolic syndrome can lead to stroke. And there is an association between the diabetic cardiovascular autonomic neuropathy and the stroke. This is a recent research on the cardiac autonomic dysfunction and risk of incident stroke, type 2 diabetes. They studied around 3,500 patients of type 2 diabetes and has found that cardiac autonomic dysfunction was associated with a higher risk of incident stroke independently of traditional stroke risk factor. Further research is recommended to find the different pathway relating the cardiovascular autonomic neuropathy to stroke. Possible mechanisms of the affection or the incidence of stroke in the diabetic cardiovascular autonomic neuropathy are heart rate dysregulation, of course, blood pressure dysregulation, increasing the sympathetic tone in the autonomic neuropathy, and also the arterial stiffness, recently the arterial stiffness, sample measure of the pulse wave velocity between the carotid and the femoral arteries. If it is elevated, more stiff, thus we can predict the stroke incidence. However, this study didn't find a clue to the incidence of the arterial stiffness or the association of arterial stiffness with neuropathy in diabetes. Not only diabetic cardiac autonomic neuropathy can lead to stroke, also it can increase mortality rate and increase the risk of cardiovascular mortality. So a home message: autonomic dysfunction in diabetes is a silent threat that can lead to severe complications, including increased stroke risk. Early detection is crucial for timely intervention and improved patient outcome. We need simple, quick, sensitive tests to implement an early screening of autonomic dysfunction in diabetic patients, especially in high-risk group. Thank you.
Thank you, Dr. Ahmed, so much. And Ahmed started the project of autonomic lab in his doctorate degree thesis, right? And I think in Tanta University, they are the first center to do this in neurology. I don't think that in other universities did. So I encourage this so much because you save a lot of patients with autonomic neuropathy. In, for example, a patient with a stroke and they don't know about it. And of course, on our patient with several types of neuropathies. Questions to Ahmed? A lot of questions.
Thank you so much. Very interesting. Thank you so much. But I wonder for this patient that you find cardiovascular autonomic positive, despite that his nerve conduction is completely normal, even in the lower limbs.
Even if waves velocity is
yes, that's okay. That's what I want to ask you. There's a relation between peripheral neuropathy, sensory motor, which is diabetic patients, and the autonomic. What I say, can I suspect this patient for nerve conduction? He has autonomic, because I can't do this test to each patient. From your study, there is no relation between both?
You know, just know that the autonomic neuropathy, it's a fiction, it's early affection in diabetic neuropathy, is small fiber neuropathy. Traditional nerve conduction studies doesn't give us a clue to the fiction of the autonomic system. Maybe skin biopsy is a gold standard to, and the autonomic nerve function tests are the gold standard for the measurement of the cardiovascular autonomic affection. These tests are done with a simple EMG. Simple EMG, we are measuring the RR interval, and we are analyzing the variation by different maneuvers like active standing, Valsalva, and the deep breathing. And this is it. The simple, our simple EMG by a certain software can measure autonomic affection in diabetic patients.
If I found a patient diabetic and I perform nerve conduction and I found sensory axonal neuropathy or motor axonal neuropathy, that's what I want to say. This patient is mandatory to perform cardiovascular autonomic for him?
This is the dilemma.
There is no relation.
Okay,
that's
this is
what
the
my
dilemma.
question.
And recent studies found that there is subclinical heart rate variability in diabetic patients earlier, 1 year to 2 years after diagnosis of diabetes. There is no recommendation, strict recommendation, may I ask Dr. Heba about this, for the screening of autonomic neuropathy. There is a recommendation for screening of neuropathy as diagnosis of diabetic 2 diabetes and 5 years type 1 diabetes. And studies are talking about the incidence of neuropathy even before the discovery of diabetes. But there is no definite recommendation to screen for autonomic neuropathy in diabetic patients. And this, unfortunately, autonomic affection has a rule. Alpha lipoic acid, it's not a very sure. I'm not very sure about this. Okay.
Thank you so much for the excellent talk. I want to comment on your question, Dr. Sausan. I had a long discussion with Dr. Peter Dick at Mayo Clinic about the coexisting of large fiber abnormalities along with small fiber abnormalities. So, I agree 100% with what you have said, that nerve conduction studies detect only large fiber abnormalities. However, in patients with small fiber abnormalities, Dr. Peter Dick argues that we should find some minor abnormalities on EMG as well, because it's a spectrum. So he thinks, and his son Jem Deck also agrees with this, and I do agree as well, that if the patient is complaining of small fiber neuropathy and he has abnormalities on skin biopsy or autonomic tests, I should find minor abnormalities on EMG. But if the EMG is completely normal, then I will not be entirely sure that the skin biopsy or the autonomic function test will yield a lot. So this is a point of debate. It's still debatable, but I think it's a very important.
Some said that if we have latency, maybe prolong it early with the affection of the autonomic system, but no, yes.
Yeah, I agree. Thank you.
Thank you very much. I wondering about the
بسم الله الرحمن الرحيم. What does neuropathy conceal at diagnostic journey? A case study. A 27 years old male working as a clerk, married with one offspring. His past medical history was unremarkable. He suffered from COVID-19 infection in December 2020 in second wave in the form of high-grade fever, dyspnea, and pneumonia. The patient received antibiotics, steroid, and the patient improved over 2 weeks. 4 months later, at April 2021, he developed paresthesia, electric-like pain in both lower limbs, started in both feet and ascends to knees with unsteadiness and tendency to fall on eye closure. He received neurotonics without any improvement. 2 months later, at June 2021, he started to complain of weakness in the foot, more in the left side, with frequent slipping of the slipper. At this time, he received AstraZeneca vaccine with marked worsening of the sensorimotor symptom with complete foot drop bilaterally 2 weeks post-vaccination. Physical examination revealed distal hypotonia and weakness of lower limb. Dorsiflexors were grade 0 and plant flexors were grade 1. Areflexia with glavant-stocking hypoesthesia with sensory ataxia. Nerve conduction studies were done at September 2021 and show evidence of primary sensor motor demyelinating polyneuropathy affecting more post-lower limb. You can see IDB distal variant. Conduction study in both lower limb were absent sensor motor, while in the upper limb there is evidence of primary demyelination in sensor motor nerves. Routine lab were normal, including ASR, so post-COVID CIDB was considered. At this time, many research were reported that COVID-19 infection and its vaccination can induce inflammatory neuropathy, including CIDB. Patient received steroid with 2 courses of intravenous immunoglobulin with mild partial transient improvement. كان على مستوى السنسوري الباراسيزيا and sensory attacks. So rituximab was given and a dose of 375 mg per square meter weekly for 4 weeks with also poor response. During this period, the patient was discovered to have Hashimoto-thyroiditis, starting to complain from fatigue with tendency to fall asleep and weight gain about 15 kg with thyroid swelling and started levothyroxine with therapy with improvement. Due to the poor response of the neuropathy to the different immunomodulation, searching for primary etiology was mandatory, so the patient was tested for serum protein electrophoresis, bone marrow biopsy, serum anti-MAG, and PET-CT scan. Anti-MAG was positive, was negative, thyroid antibodies and TSH were elevated, and the ultrasound suggesting chronic autoimmune thyroiditis. Protein electrophoresis showed evidence of band observed in gamma globulin suggesting monoclonal gammopathy, and the immunofixation revealed there is elevation of lamina light chain and the serum IgG. Bone marrow was normal, and PET-CT scan revealed a large metabolically active destructive osteolytic bone lesion involving the left acetabulum, and the biopsy was going with intraosseous plasmacytoma. Plasmacytoma, it is a plasma cell tumor that grows within soft tissue or within the skeleton. We have 3 types: solitary plasmacytoma, extramedullary plasmacytoma, and multiple plasmacytomas. It is very rare to occur at rate of 450 cases per year, affect people above the age of 50 with more male predilection. The most common is solitary plasmacytoma and accounts 35% of all plasma cell malignancies. It occurs as lytic lesion with the axial skeleton, and the extramedullary plasmacytoma often occur in upper respiratory tract, but also can occur in soft tissue. Half of all cases produce paraproteinemia, and about 50% of solitary plasmacytoma develop multiple myeloma within 2 to 4 years. Differentiate from multiple myeloma by presence of only bone lesion, other on bone or soft tissue, normal bone marrow, normal skeleton, absent or low paraprotein, and no end organ failure. During the course of disease, the patient was found to have skin lesion, بدأ يبقى فيه rash in the proximal arms, proximal upper limb in arms and chest, and lower limb edema start to appear with blood changes. السكين rash بدأت تأبير في الارم and with widening of proximal nails. Lower limb edema start to appear with polycythemia and thrombocytosis. So the patient had polyneuropathy, Hashimoto-thyroiditis, monoclonal gammopathy of IgG type, plasmacytoma, skin manifestation, peripheral edema, and blood changes. So the diagnosis of POMS syndrome was considered. The treatment, when the bone marrow biopsy is normal, It depends on the number of bone lesion. If less than 2 bone lesion, the treatment will be radiotherapy. If more than 2 bone lesion or with malignant plasma cell in the bone marrow, the patient can be subjected to bone marrow transplantation. If cannot tolerate, we can give chemotherapy, then reevaluate the patient for bone marrow transplantation with monitoring every 3 to 6 months. So the patient was planned to receive 21 sessions of radiotherapy for plasmacytoma, which is radiosensitive, and 3 months later, bone marrow biopsy was done as a follow-up, and there was evidence of systemic spread with 11% atypical plasma cell in the bone marrow. ده كان اللي هو البون marrow biopsy. The patient received VRD regimen, linalid, bortezomib, and dexamethasone. There was a good response to the regimen as evident by follow-up bone marrow biopsy, protein electrophoresis, CBC, and PET scan. بدأ البروتين electrophoresis normal, blood cheese بدأت تتحسن, immune fixation was normal, and PET scan show metabolic regression of the left acetabulum destructive mixed histolytic and sclerotic bone lesion. First PET scan shows that evidence of lytic lesion, but follow-up shows that this lesion is histolytic and sclerotic. As regards the neuropathy, follow-up nerve conduction study showed no evoked sensor motor potential in both upper and lower limb, and there was a physical rehabilitation for about 1.5 years with partial improvement as regards the motor symptom. الفوت دروب بدأ يتحسن and الجيل, but still paresthesia is so irritating to the patient. And the patient was subjected to autologous bone marrow transplantation 3 weeks ago. This case can be summarized in terms of monoclonal gammopathy associated neuropathies. Monoclonal gammopathy compromises a spectrum of clonal plasma cell disorders that include monoclonal gammopathy of undetermined significance, MGUS, multiple myeloma, Waldenström macroglobulinemia with 2 specific plasma disorder, POM syndrome, and amyloid light chain amyloidosis. The hallmark of this disorder is secretion of monoclonal immunoglobulin, referred as M-protein. Peripheral neuropathy is a complication of gammopathies with a difficult clinical problem in the term of diagnosis and treatment. Epidemiology, polyneuropathy can occur in patients from pre-malignant MGUS to overt malignancy in multiple myeloma and Waldenström macroglobulinemias. MGUS is relatively common. It presents in about 5% of general population above the age of 5. So the occurrence of neuropathy in patients above the age of 5, usually the relationship is coincidental and not causal relationship. MGUS is a pre-malignant precursor of multiple myeloma. We have 3 major types of MGUS: IgM MGUS, non-IgM, IgG, and IgG, and light chain MGUS. Progression to the malignancy is the main consequence in MGUS, and they occur at rate 1% per year. IgM MGUS usually progress to Waldenström macroglobulinemia, non-IgM to multiple myeloma, light chain multiple myeloma, and all forms can progress to AL amyloidosis. The other main consequences of MGUS, immunological reaction to the M-protein producing polyneuropathy and glomerulonephritis. Polyneuropathy occur in about 3 to 5% of patients with MGUS, especially IgM. About 60% of patients that affected in MGUS usually have IgM MGUS, and less commonly IgG and the IgA. Also, great number of multiple myeloma can have neuropathy at the onset of disease, during the course, or drug-induced by medication used in the treatment of such disorder. Pathophysiology is not well understood, but the pathology may be due to direct effect of M-protein to the peripheral nerve, resulting in a demyelinating process. Anti-MAG was found in 50% of patients with IgM, followed by antibodies against the ganglioside, and also antibodies against ganglioside complexes. It was found that patients with anti-ganglioside antibody had equal sensory motor symptom, but usually there is no major differences between the patient according the antibodies. There is also the antibodies are not specific for MGUS. Anti-MAG also present in many diseases such as the AL amyloidosis, and also reduction of anti-MAG in patients receiving rituximab doesn't correlate usually with clinical improvement of the patient. Clinical presentation of gammopathy associated neuropathies, usually it is hard to distinguish gammopathy associated neuropathy from other causes, but there are some difference in IgM versus IgA and the IgG neuropathy. In IgM, usually the presentation usually like that syndrome, distal acquired demyelinating symmetrical polyneuropathy, usually affect men at the 6th and 9th decade of life, affect mainly large fibers, so the patient there is sensor ataxia with tremors, motor involvement usually mild and distal, cranial affection is rare but can occur, and in nerve conduction studied, it mainly demyelinating in nature. Anti-MAC found in 50% of the patient, but usually there is no in absence or presence of anti-MAC doesn't affect the severity of neuropathy. Non-IgM found all full spectrum of neuropathy can found in non-IgM patient, ranging from lens-dependent sensor motor polyneuropathy like in diabetes to the classic CIDP. Usually acts in nature على عكس IgM which is demyelinating, and there is no significant difference between IgG or IgA patient. Usually the relationship between non-IgM neuropathy and the IgM M protein coincidental and not causal relationship. Patient with and it was found that patient with IgG and the IgA M protein was also presence of antibodies against neural tissue, but in absence of neuropathy. So the relationship usually coincidental. Diagnosis: gamma-associated neuropathy should be considered when an M protein is detected during the workup of unexplained neuropathy. First, other causes should be excluded like diabetes, genetics, alcoholism, or drug-induced. Second is to determine if the relationship between the neuropathy and the gammopathy is causal or coincidental. Causal relationship it was found in patient when the patient is younger than 50 years, since the incidence of gammopathy in patient less than 50 years is about 1.5%. Causal relationship higher with IgM mangas, and if the antibody is found, usually the relationship is causal and not coincidental. ثالث حاجة في diagnosis: exclusion of specific plasma disorders that have a definite causal relationship, POM syndrome and amyloid neuropathy. POM syndrome, the case, our case is a real multisystem paraneoplastic syndrome due to underlying plasma cell neoplasm described by its name component, polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. The precise incidence is difficult to determine due to complexity of its presentation, but its prevalence in Japan, as it was discovered first in Japan, is about 0.3 per 100,000 individuals. Median age is about above the 50 with more male predilection. Diagnostic criteria of POM syndrome: we have mandatory criteria, polyneuropathy and monoclonal plasma proliferative cell disorder، وده كان البيشنت بتاعنا كان IgG type. Other major criteria لازم يكون عندي واحدة بس one required، Castleman disease which is angiovollicular lymph node hyperplasia، sclerotic bone lesion، وده كانت positive in our patient. First كانت الليجن كان ليتك، كان الريبورت مدي ليتك، وده كان against trial POM syndrome، but follow up show evidence of mixed sclerotic and lytic lesion, and this is going with POM syndrome. And there is the vascular industrial growth factor. Risk vascular industrial factor, it is plays the main role in pathogenesis of POM syndrome. It is an inflammatory cytokine that it is angiogenic cytokine that produce vascular pathologic hypervascularization in the tissue. It is raised 2 to 3 times in patients with POM syndrome. And it's used in detection and monitoring the patient. But unfortunately, the patient costly to the patient. We didn't add for the patient. Minor criteria: one is required, organomegaly, extravascular volume overload. Our patient has had lower limb edema, endocrinopathy, mainly adrenal and gonadal, thyroid and diabetes mellitus due to their high prevalence in the general population. Usually don't include in the criteria of POM syndrome, thrombocytosis and polycythemia, and others such as hypertrichosis. Polyneuropathy in POM syndrome began distally in lower limbs with severe weakness, wasting, and foot drop with sensory loss, and can progress rapidly to involve the roots with polyneuropathy and reflexy. Pain is present, and this is differentiated from CIDP. It is important to differentiate POM neuropathy from classical CIDP for diagnosis. First, in POM neuropathy, it is a lens-dependent sensor and motor neuropathy, but in CIDP, maybe patchy and affect proximal and distal fibers. Pain is present mainly in POM neuropathy, but the motor manifestation is mainly in classical CIDP. Also, other multisystemic manifestation present in POMs usually doesn't present in patient with CIDP. The neuropathy in nerve conduction study in POM syndrome, there is primary demolition but severe axonal affection. Even fibrillation can be found, but in CIDP, it is mainly primary demyelination with conduction block and with less axonal affection. Vascular and cellular growth factor usually elevated in POM syndrome but normal in patient with classical CIDP. Also, the response to the medication can differentiate between POM neuropathy and classical CIDP. Usually, POM neuropathy doesn't respond to the different immunomodulation, in contrast to CIDP, which respond to the classical immunomodulation. The bone lesion in POM syndrome are sclerotic versus in multiple myeloma, which is osteolytic. The red flag in POM syndrome, never IgM present in POM syndrome. Usually the M protein is IgG or IgG with lambda light chain. And vascular and cellular factor, it is important for pathogenesis detection and monitoring. Treatment of POM syndrome involves radiation and chemotherapy for sclerotic plasmacytoma, which usually result in significant clinical improvement of neuropathy as well as other systemic manifestation. تاني حاجة في differential diagnosis في gamma associated neuropathy, amyloid neuropathy. It is present neuropathy in amyloid.
أسماء will be shortly. أسماء يعني الكيس بتاعتك الحقيقة كانت رائعة.
Two slides.
عشان بس لسه عندنا حالتين عشان نبقى in schedule. Just shortly please.
2 slides. Neuropathy and amyloid neuropathy usually there is sensory and autonomic manifestation, more upper limb affection with axonal affection, and the course usually debilitating and progressive. While in gammopathies, the course is extended stable period. رابع حاجه في الدياجنوز لازم اعرف النيتشر بتاعت الاندرلاينج جاموباثي، هل هو بري مالجنت مانجس اور مالجنت مالتيبل مايلوما. and finally should evaluation of the neuropathy should be done to determine whether therapeutic intervention targets the M protein or not. ده كان الالجوريزم اللي احنا قلناه. treatment when I found M protein with polyneuropathy، اول حاجه is IgM monoclonal protein or not. If IgM, is there evidence of Waldenström macroglobulinemia or not? If it is present, we should treat. No evidence of Waldenström macroglobulinemia. It is that trial of IVIG, no response, consider rituximab. If no IgM monoclonal protein, evidence of multiple myeloma, if present, هعالج كمultiple myeloma. No evidence of multiple myeloma, clinical precision to IDB, هعالج like classical IDB. Non-IDB phenotype, يبقى لازم اعمل continuous evaluation for alternative causes. Prognosis, about 25 to 30% of patients have moderate disability at 10 years. Significant improvement in neuropathy of POM syndrome can take up to 3 years. Home message: all patients presenting with inflammatory polyneuropathy should be investigated for monoclonal plasma cell disorder. If abnormal, they should be considered for serum vascular and cellular growth factor. Not all patients with POM syndrome present with the classical feature described in the acronym. The clinical approach to polyneuropathy with gammopathy should be guided by gammopathy subtype, clinical and electrodiagnostic phenotype of the polyneuropathy. Thank you.
طبعا بشكرك يا اسماء. Thank you so much for your case presentation and you reached up to bone marrow transplantation to save your patient and you have good results. And of course, because you read a lot about the subject, she wants to tell you everything. Thank you so much. I want to ask one question about monoclonal gammopathy. Your type, is it usually sensory or sensory and motor, or it could be purely motor?
According M protein. According M protein. In IgM protein, it is mainly sensory, affect large sensory fibers.
Mainly sensory.
Mainly sensory. In non-IgM, IgG and or IgA, all type of neuropathy can occur from sensory motor to CIDP, which is mainly motor. So IgM mainly sensory large fibers, and the motor affection is very mild. But in non-IgM, sensory motor or even motor can occur as the relationship usually is coincidental. In POM syndrome, presentation mainly sensory, but there is severe distal weakness.
Yes. Okay, questions? حسونا معاك.
السؤال دلوقتي انا شكيت ان العيان ده عنده بارابروتينيميا، وعملت طلع مثلا في البروتين الكتروفوريسيس عندي مونوكلونال جاموباثي فاندرماين سيجنيفيكانس او اي جي ام، وعملت بعدها او هايبر جاما جلوبينيميا، عملت بعدها لقيت عملت بيت سي تي وعملت وما لقيتش اي بلازما سيلز اوردر او حاجه. ساعتها حضرتك قلتي ان برضو مش هقدر احدد هل النيوروباثي اللي عندي ده من يعني ده بارابروتينيميك نيوروباثي ولا لا، صح؟ انا فهمت كده مظبوط؟
اكوردنج الايموبروتين. لو الايبوبروتين اي جي ام غالبا بيبقى فيه كوز ريليشن شيب مع النيوروباثي، تمام. نون اي جي ام او اي جي جي او اي جي اي غالبا الريليشن كوانسيدنتال، فلازم ادور على ايتيولوجي تاني، يعني ما اعتمدش ان ده مونوكلونال جاموباثي اسوشيشن نيوروباثي على حسب الايموبروتين، على حسب الايج. لو كان البيشنت اقل من less than 50 years غالبا كوز ريليشن شيب، انما above 50 غالبا كوانسيدنتال.
لازم برضو اكسكلودينج اذر ديفرنشال يعني
فيرست اول حاجه في الدياجنوز اصلا جاموباثي لازم اكسكلود اذر كوزز، دايابيتس، جينيتك، الكحوليزم، دراج انديوز، لازم اول حاجه اكسكلود الاذر كوزز.
طيب المونوكلونال جاموباثي في انديترمايند سيجنيفيكانس ده لاب، يعني هم في اللاب بيقدروا، حضرتك عندك معلومه بيقدروا يعني امتى يقولوا ده انديترمايند سيجنيفيكانس او امتى يطلع ان في هايبر جاما جلوبينيميا، ولا دي حاجه لاب
اكوردنج الايموبروتين؟ لو طلع عندي الايموبروتين ما فيش اي ايفيدنس ان يكون عندي مالجنسي شكل في حاله المالتيبل مايلوما او الفالدر سيرام ماكروجليبيمياز بالكلينيكال مانيفستيشن واللاب بتاعها، يبقى ده غالبا اوف انديترميند سيجنيفيكانس.
يعني هم يعني انا قصدي الانديترمايند سيجنيفيكانس ده المقصود بيه ان انا ما فيش ريليشن مع مالجنسي، يعني ده بقوله بعد ما بعمل البيت
ده بري مالجننت، ده بري مالجننت محتاج فول اب بعد كده. يعني انا خلاص وانس لقيت ان البيشنت عنده ايموبروتين وفي نيوروباثي او وات ايفر وزود نيوروباثي، تمام، لازم البيشنت ده هعمل له فول اب بعد كده، لان ده غالبا لان ده اصلا موجود الايموبروتين ده موجود في 5 من 5% of people above the age of 50. محتاج ان انا ده بري مالجننت، محتاج ان انا فول اب. قبل ما اقول ان انا محتاج في الاب لازم طبعا هدور على المالجنس الاوفر، يعني انا بالظبط كلها فري، يبقى ده غالبا ده مقص، محتاج ان انا بري مالجنس، محتاج فول اب بعد كده.
تمام، شكرا.
Thank you. We have to shift to the next case presentation. So we have, thank you, Esma. We have Dr. Aya Mohammed Mikawi from Assistant Lecturer in Shams University. Aya will have a case with congenital myasthenic syndromes versus mitochondrial myopathy. Okay, so we will shift. We will start with Minna until Aya will search for her case. دكتورة منة مجدي الجمل. She is assistant lecturer in Ain Shams University. Minna will present another similar case, a case with congenital myasthenic syndrome versus mitochondrial myopathy. ممكن لما يبقى عندنا presentation نبقى مدينهم من بدري التوكس بتاعتنا زي ما انا بعمل دايما. طيب شكرا.
Good morning, dear professors. Good morning, Dr. Nagia. Today we will present a case. It has a problem for diagnosis. NIA, 6 years old female patient, born and lives in Al Bahira with no special habits of medical importance. Her complaint was bilateral upper limb and lower limb weakness. Family history, strong family history of cancer colon and cancer prostate in males and breast cancers in females in both maternal and paternal sides. Past and developmental history, normal motor, speech and mental milestones, no remarkable past history. This is her family pedigree. She has a sister elder than her, 8 years old, with cerebellar ataxia and cerebellar atrophy and ataxia. History of present illness. The condition started with rapid onset regressive course on treatment of 1 year duration when the patient developed high-grade fever for 3 days, which subsided on antipyretics. 3 months later, the patient started to develop bilateral upper limb and lower limb weakness, affecting proximal muscle more than distal muscles, both upper limbs and lower limbs, to the degree that she experienced frequent falling, inability to climb the stairs without assistance, and inability to raise her hands above her head with diurnal variation. Few days later, patient started to develop drooping of both eyelids with more affection of the left eyelid, mild inward deviation of the left eye. The child in that time didn't account on if she sees the object as if to or not. Few days later, started to develop facial muscle weakness with drooling of fluids from both angle of mouth, inability to masticate food properly, difficulty of swallowing to both solids and the fluids with nasal regurgitation to fluid, and changing of the tone of voice with nasal intonation. All of these symptoms were associated with fatigability and diurnal variation. Patient sought medical advice and pyridostigmine was prescribed. Patient showed improvement regarding her symptoms on it, but the mother observed worsening of her symptoms when she missing any dose. Patient sought another medical advice and prednisolone was added to the pyridostigmine, and patient showed much improvement regarding his symptoms. All through the history, there is no other motor, sensory, cranial nerve, or cerebellar symptoms, and no history of seizures. Regarding general examinations, there is no remarkable finding. Regarding neurological examination done February 2024, the patient is conscious, attentive, oriented, speech no dysarthria, cranial nerve intact except regarding oculomotor and abducent and trochlear. There is bilateral horizontal and vertical nystagmus. Regarding cranial nerve, trigeminal, weak temporalis and masseter. Regarding facial nerve, elicited jaw but weakness of facial muscle, orbicularis oculi, orbicularis oris, and buccinator muscle. Regarding her motor examination, no fasciculation, no atrophy, and there was a hypotonia around ankle and wrist. Power, weakness of both upper limbs and lower limbs, proximal equal distal in the upper limb and proximal more than distal in the lower limb, extensor of elbow more than flexors, abductors more than adductors, weakness of small muscle of hands, flexors of hip more than extensors, and extensors of knee more than flexors with positive Gower sign. Regarding coordination, positive left side finger to nose and heel to knee, and ataxic gait to the left. Reflexes, regarding deep reflexes, lost upper limb deep tendon reflex and elicited lower limb reflexes. Superficial intact with bilateral extensor plantar. Gait ataxic to the left and intact sensory examination. Last examination done 4 of September 2024, patient is conscious, attentive, and oriented. Regarding her cranial nerve, there is bilateral improvement of her bilateral horizontal and vertical nystagmus, intact muscle of mastication, elicited jaw and intact facial muscles. There is no fasciculation and no atrophy and no hypotonia, and her weakness has the same distribution like in February 2024. regarding reflexes, loss to upper limb, deep tendon reflexes, and elicited lower limb reflexes. Coordination, improvement of her ataxic gait regarding her last examination in February 2024, and fatigability test showed positive with appearance of ptosis more on left side. Regarding her examination, which is remarkable, it has a borderline ionized calcium level and deficient vitamin Z level. EMG was done in 2023. Positive repetitive nerve stimulation in upper limbs and lower limbs and face, although EMG showed positive waves, fibrillation and myopathic unit in proximal more than distal muscles. EMG done in September 2024, positive repetitive nerve stimulation and myopathic motor unit potential with no spontaneous activity. Acetylcholine receptor antibodies was done twice and was positive. Autoimmune myopathy panel was negative. CT chest, no enlargement of the thymic gland, and MRI brain was done and it was normal. Our differential diagnosis, it is autoimmune myasthenia associated with autoimmune cerebellar ataxia, or it was mitochondrial myopathy or another thing else. Thank you so much.
You have the patient? Okay. ممكن تيجوا من هنا حبيبي، تعالوا من هنا. Two sisters, one with cerebellar ataxia and the other with cerebellar ataxia and myasthenia. But it looks like autoimmune because it responded to mistinone and responded to steroids. اهلا اهلا وسهلا، ازيك؟ اهلا اهلا اهلا، ازيك؟ لا صاحبتي، ازيك؟ تعالي هنا مع بابا يلا.
She does not look very ataxic. It looks very normal on appearance. Yes. So, of course, your main question whether this is basically a myasthenic problem or could there be some mitochondrial myopathy involved? I have difficulties to see these changes with therapy on a mitochondrial background. So definitely there has, and you have the antibody positivity, you have the neurophysiological results suggesting a myasthenic problem. So for me, there is definitely a myasthenia.
The EMG done twice and shown myopathic motor unit potential.
Yes, but it's not unusual to see some myopathic features on EMG, and also depending on who is doing and reading, you can have some differences in results. So I would not bother much about that. As soon as the clinical situation is more or less improving and stable, and CK level is normal. Yeah. Yes. Yes. So that is a different problem, of course, and there is her condition genetically clarified. Is there a
no.
gene? No.
No.
I mean, should be a recessive type of genetic ataxia, spinocerebellar ataxia.
A different type, not the same, not the same pathology in the in the girl and her sister.
Yeah. Okay. No, I mean, if you have a recessive gene in the family for ataxia, parents are heterozygous. SIBs can be heterozygous, and you can have some, of course, interference from that, but I would not bother about that.
And the ataxia that was seen in her initial examination, you recommend it was an autoimmune process, as it improved on steroids.
Yes, and we have difficulties to know what it actually looked like. So could you just run back and forth?
No.
Yeah.
No.
Yeah. 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 Good. And run.
رن اجري يا نور اجري. تعرفي تجري لغايه هنا؟
Fast. Fast. Yes. Yes. I mean, does not look very ataxic, no.
اقعدي على الارض يا نور. افردي رجلك قدامك. اقعدي على الارض زي ما عملنا المره اللي فاتت. اقعدي لا اقعدي خالص.
والاخت جالها
قومي بقى اقفي.
مايسينيا ولقوها اتاكس. خدت الستيرويدز والستينول اتحسنت. فمنى تقول هل لهم علاقه ببعض ولا لا؟
A bit weak, but not very severe.
Actually, last examination, the flexors of hip grade 3 plus.
Yes.
And other muscles
But there
about
were
grade 4.
some concerns regarding reflexes, I think.
Her upper limb reflexes was lost, but the lower limb is normal. استاذنك بس نرفعها على السرير. لا.
Sorry, yes, we are thinking about this is two pathologies. It looks like autoimmune. In the last 3 months, I saw some children with autoimmune attacks and improved in steroids. Like good.
Minor response.
بالظبط فده كنا بنفكر كده بس البنت اتحسنت تماما. الثانيه عندها الاتاكس لكن اتحسنت.
There is a difference with her lower limb.
هنستأذنه شكرا معانا قبل ما يمشي. دي حاله يعني في الاخر بنركز في ايه؟
لا مش مايسينيا. just ataxia. الام ار اي فيها cerebellar atrophy. normal. ممكن الرنين المخ اللي عملناه بتاع نور. لا الافلام نفسها.
Quite normal in the low limb.
normal. كان بوست بابينسكي.
يعني دول مش موجودين بوليسيز كونجنتال.
هي برضو lost reflexes او minimal reflexes على الupper limb وانتكت reflexes على اللور limb. ده الام ار اي برين بتاعها هو نورمال ما فيهوش بتاع 8 سنين. 8 سنين.
Because you have some nystagmus, yes, there is some nystagmus. And that is of course not a myasthenic problem. So there is some of course central nervous issue beyond myasthenia. Whether that relates to the ataxia genetic background in the family or not is of course difficult to tell. I would just keep following that. We don't know when it has started because it makes no major visual impact for her, and I would just keep an eye on that, on repeated examinations to see if it changes over time or not.
Thank you. Do you recommend to do genetic tests for her and her sister?
I would like to know the genetic background of the ataxia, spinocerebellar ataxia with cerebellar atrophy in the sister. Yes, I would definitely.
It may be related to her ataxic symptoms?
Difficult to know. Can't know.
No, ممكن just ataxia. myasthenia plus ataxia. هي كان عندها
عندها weakness وفاتيجابيليتي وتوزس وديبلوبيا مع diurnal variation وبوزيتيف repetitive nerve stimulation improved على الميستينون. كانت الأول بتاخد ميستينون only، بعد كده لما كانت ميس دوز ويحصل ريجريشن للكيس بتاعتها اتضاف كورتيكوستيرويدز بريدنيزولون، بدأ يبقى يحصل فيه improvement.
We do not see any major
Her ataxic
coordination
symptoms although
problem.
improved with
We do not see any clear coordination problem for her now. No ataxia. The only issue beyond the symptoms that responded on treatment is now her nystagmus in the eyes, which remains an open question for me. Very good girl.
طيب اوكي منى هتقعدي مع العيله تفهميهم الحاله. Last speaker before the break is Dr. Aya Mikawi. Aya is assistant lecturer at Ain Shams University and will present another similar case about congenital myasthenic syndrome versus mitochondrial myopathy.
Okay, I'm going to quickly present this.
No,
case.
you have time before the break.
Okay. Mr. AA, 29 years old, born on the 3rd of July 1995, single, born and lives in Menofia, works as nurse. He doesn't have any special habits of medical importance. His main complaint was bilateral dropping of eyelids and nasal intonation of voice. Past history is insignificant, except for migrainous attacks, started last 2 years, aborted by triptans, and he didn't need any prophylactic therapy. This is the family pedigree. It shows our patient is down, pointed at by the arrow. The family pedigree of similar condition suggests possible autosomal recessive
Why not autosomal
inheritance.
dominant?
Or autosomal dominant.
No, which of which? Autosomal dominant or autosomal recessive? I can't find consanguinity. Is there a consanguinity here?
No consanguinity.
Okay, you have a patient in every generation, males and females. What do you think? What do you think, Professor?
But because I thought because the parents were not necessarily affected, like we have the second and the third generation affected, but the first generation we have no affected family members. That's why I went with.
But his father.
So is the type of disease exactly the same in all these individuals?
Yes, except for with younger generations, the disease appears earlier in onset. For example, our patient started at the age of 16, his father started at the age of 30, 35, and he has more severe phenotype than his father or his uncles.
Is what we call anticipation?
Yes.
Okay.
It's a bit peculiar, but I mean, if you could see a pedigree like this in myotonic dystrophy, but this is of course not myotonic dystrophy.
I found this autosomal dominant because the father is affected, and also there is that anticipation, which usually occurs in autosomal dominant.
Yes, very rarely beyond myotonic dystrophy, but so are they alive, the
Yes.
third generation?
Yes, they're still alive. They are still alive.
And grandfather and grandmother, grandfather
Some of them are still alive.
and they have nothing.
Yes, they don't have anything. Like the affected members of the family are the father, the uncle from paternal side, and his grandfather's sons. And I don't know if I have a pointer.
You have a point. Yes, this one.
So let us go to the phenotype and then go back to the pedigree to see.
Okay. Okay. Regarding the history of present illness, the condition started at the age of 16 years with gradual onset, progressive course, when the patient started to notice bilateral dropping of eyelids. It increased with fatigue and exercise, but it was not associated with diplopia or color affection without the urinal variation. At the age of 20, he started to notice also change in his tone of voice, with nasal breathing upon speaking for long times, and especially during reciting Quran. He sought medical advice because the toses and the nasal intonation, they were not improving at times. He was deteriorating gradually, and he received mistinone, QID, and Solipred 60 milligram daily without any improvement. At the age of 21, he started to develop dysphagia, more to solids than fluids, which was persistent without any diurnal variation or fatigability. At the age of 24, he started to develop nasal regurgitation, mainly to fluids. At that point, he sought medical advice, receiving multiple sessions of plasmapheresis without any improvement. And he was still on oral medications. The neurological examination regarding the cranial nerves, there was horizontal ophthalmoplegia, especially on looking to the left side more than the right, bilateral facial weakness, uveal deviation to the left side, diminished bulbar reflexes, both deep and superficial, with weak tongue muscles, but there was no atrophy, hypertrophy, or fasciculations. Speech showed nasal intonation and weak voice. Motor examination was MRC scale grade 5 all over, and reflexes were lost all over, or severely diminished all over. Fatigability test by sustained vertical eye holding for 1 minute was positive. Patient developed ptosis, especially on the left side, after around 30 seconds. Sensory examination, both superficial and deep, and coordination showed no abnormalities. Gait also had no abnormalities. Regarding investigations, laboratory investigations showed high CPK, which was 920, with an upper limit of 45. Anti-acetylcholine receptor antibodies and anti-MuSK antibodies were negative. Serum lactate and pyruvate were within normal range. Regarding electrophysiological tests, patient had done nerve conduction and EMG while on mistinone, which was normal, but repeating them after stopping of mistinone and Solipred for 3 weeks, repetitive supramaximal stimulation showed positive decremental response. I wanted to demonstrate the photo of the patient when he was younger, because he didn't actually have any symptoms until the age of 16 years, no ptosis and no facial weakness.
Was there a mild left weakness on the eyelid on the photo? I think it's at least suspect.
No, okay.
In congenital myasthenic syndromes, is there increase in CK serum level? No.
Not that I know of.
No.
No.
In mitochondrial disorders, is the serum CK is high?
I want to mention something. That in the beginning we had the mitochondrial myopathies and congenital myasthenia as differential diagnosis, but currently we are more directed towards congenital myasthenic syndromes versus less probably oculopharyngeal muscular
I'm
dystrophy.
just discussing easily. When we have this CK high, so there is a muscle disease in this patient. So it could be a mitochondrial myopathy, We look for the congenital myasthenic syndrome. Is there any genetic defect with muscle also? We look for this. If not so, this will be omitted. But this pedigree, you have the patient and the father and the grandfather affected. No, I will think about autosomal dominant.
Dr.
And
Malish,
I'm sorry?
maybe the pedigree is not very clear,
Ah.
but the father is affected, but the grandfather is not affected.
مش
عارف.
So, what is the clinical situation of the father? Does he have the same cranial nerve problems?
Yes, but he has minimal facial weakness, bilateral dropping of eyelids, dysphagia, but all the symptoms are way minimal than our patients and presented at an older age of onset.
Mm-hmm. Okay.
No myotonia. Yes, and I did the myotonic. Yes, and I did the myotonic tests. They were negative. Dr. Ann, yes.
She's a professor. Okay. So differential, you will bring the patient first and differential diagnosis. Where is the patient?
My differential diagnosis became more quite constricted.
We'll see the patient. It's a very interesting family.
What is the expression of anorexia? Muscle disease or anemia?
We did
تفضل،
examination
تعال
of the patient multiple times at occasions, and he was areflexic. But more, some doctors found severely diminished reflexes. But in my examination, I didn't get any reflexes.
And we do not have any muscle imaging or muscle biopsy, no?
No.
Not yet.
I wanted to ask if we should.
Okay. So we have to see the patient again. We have to see the patient again with Professor Oud and see what we have to do. This is a very important family. ممكن النور نور لنا النور بعد إذنك.
Currently not, because he didn't improve any bit on Mistinone or Solipred. He didn't improve.
Just by looking at his face, of course, you would think of a mitochondrial problem in the first place. That would be the sort of, but peculiar pedigree makes no much sense at the moment. I mean, if the pedigree is correct, and all the marked individuals have the same disease, then it has to be a nuclear problem, because I mean, if you think of a maternal line of sort of taking over the disease from generation to generation, the pedigree does not fit very well. Okay, so we have a face that and when you close your eyes very firmly, yes, close, so very weak also all over, and you make, yeah. So there, and you open your mouth and out with the tongue, nothing much here, yes, okay. Can you blow? So very weak all over, and keep. That's good. Okay, and then we will have a look at the eye movements. So here we have a deficit with some lateral nystagmus on the side that does not move correctly. So an overall, all cranial nerves more or less affected?
Yes.
Mm.
Also, he
Mm.
has tongue and
Yeah, I understand you. And bend down the head. Keep. Not very bad. And backwards. Normal.
in age of 16 years. He's currently 29.
Keep.
He's currently 29.
Up with the hands. Spread out. And flex. Normal strength all over.
Yes. He had normal strength all over, but in my examination, the reflexes were diminished to lost.
That will, of course, be tested now. Next.
Reflexes are lost.
We need clearly more data on the muscle. And even if the strength is normal in the upper limbs, I would definitely also use a muscle MRI. The muscle bulk is not very prominent, so I would expect for his age a bit bigger bulk in small hand muscles all over, but it's not a clear atrophy. What is he doing professionally?
He's a nurse.
Okay.
And he reports on work intolerance and easy fatigue throughout the day.
Okay. But manages? Is there what is the change over 1 year? How much better could he do things 1 year ago than now?
عبد الرحمن، هو انت يعني حاسس ان انت بتتدهور او يعني زي ما انت من السنه اللي فاتت للسنه دي ولا ايه زي ما انت؟ طب من سنتين ماشي، كنت احسن بقد ايه من سنتين؟ He says that last year he was the same, but the year before it he was better with around 5% difference.
So some slow progression, some slow progression.
Yes.
But for the last year, no major change.
Yes.
Very good in that sense, yes.
I would like to.
Peculiar.
I have a question. Can we think about some of the genes of congenital myopathies that also cause myasthenia or myasthenic symptoms, like Ryan gene, R1 related disorders? Yeah.
We have a
Must be
number.
myopathy, congenital myopathy with myasthenia.
We have a number of genes that
Cause both.
are reported either to cause myopathies or myasthenic problems or both.
Or both, yes.
So GMBBP is one of those genes, and I'm sure there are more. Because if you look at the complexity of the end plate on the muscle side, there are very many genes, proteins in those complexes, and by far, I think only half of them or less than half of them have so far been clearly associated with muscle diseases.
Yes.
There is.
Some of them
bleeding
also
more.
has skeletal deformities,
Yes,
like
yes,
scoliosis or high arched palate. Is
But,
there any skeletal deformities?
You open the mouth again, a bit high arch, but
No.
not prominent.
Okay. So I think we have to continue
Yes,
investigation.
Yes, we need a muscle biopsy as well. I would do the MRI first to have a look where to go for the optimal biopsy site, and then also, yes, yeah, and of course. He is probably now has the most symptoms of all of the family members.
Yes.
Are all other milder?
He's more severe than other generations.
هو
انت حالتك اصعب منهم؟
أحسن برضو؟ everyone is better. Everyone shows milder phenotype.
What about oculopharyngeal muscular dystrophy?
This is I wanted to ask about this as well.
Yeah.
Autosomal dominant and CK is high.
Yes.
Dyspnesia
We have a new category. I would not, with his strength in his proximal muscles, I would not think of OBM. But we have a new category of oculopharyngeal distal myopathies with very variable phenotypes. And I mean, he has not a particular distal weakness, so it's not directly in that group. But when looking at the pedigrees and families that have been reported with oculopharyngeal distal, there is a wide range of variations, and those are repeat expansions. And the repeat expansions can behave very differently. Many of the families reported do not have a complete segregation of the disease in the families, and that is currently explained by these repeat expansions, that some of them have interruptions. And then you have a milder phenotype if the repeated stretch is interrupted by some non-repetitive sequences. And it's very complex. We don't know all of the story.
First, do the muscle MRI to see which muscle is affected, and then we have muscle biopsy.
Yeah.
It can show if there is muscle biopsy here. It's very important.
Yeah.
Dystrophic changes, rimmed vacuoles, mitochondrial changes.
All of these, yes.
And according to result, we will choose a genetic test.
I
We
would
will not
definitely collect DNA samples of as many as possible. This is a pedigree where you could do linkage studies and clarify where the defect lies, if it is in any of the known genes or if it is
if it is a new gene.
Yeah.
So it is your responsibility, Aya. I will follow up مع Aya. وشوف
clarify. We have to know what this disease is.
ان شاء الله هنساعدك باذن الله، ربنا يقدرنا. فاحنا نشوف الحاجات اللي هنقدر نعملها عندنا، وممكن لو في انشورنس تبع الكليه عندك هنعملها، واللي مش هنقدر هنكمله برضو حتى لو بعتنا البروفيسور مثلا DNA او حاجه يساعدنا يعني.
I have a question.
Last question because we have a break يا آية.
Do you recommend using beta blocker salbutamol as a trial to see if the patient is going to improve? Because congenital myasthenia improves on.
You can try. I would not expect any.
يعني آية عايزة تدي كل الأدوية بتاع الكونجنتال مايسينيا until proved otherwise.
Easy medicaments you can try and see.
Okay, so we have break now. We will be here exactly before 1:30 because yesterday you didn't come 1:30. We'll be here 1:20, so we can start the workshop, a very excellent workshop today. 1:20.